Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas.
Welcome back to the program. This is Aebhric O'Kelly. This week, we are again with Greydon Ratushny, who joined us a year ago as he talked about his master's experience, but now he's finished. And he is a master's graduate of the Austere Critical Care program, starting his DHS, his Doctor of Health Studies with the college. Greydon, welcome back to the program.
Aebhric, absolute pleasure to be back. Thanks for having me back.
So tell us about your experience with the Masters of Austere Critical Care.
It was one for the books, I can say that much. I've done a little bit of dabbling in graduate studies here over the years, and overall, what I found that the ACC program, the Masters of Austere Critical Care, was an amazing blend of remote learning, in-person learning, outstanding facilitators, outstanding cohort of other students in the program, and just overall an amazing experience. Probably one of the highlights, and I know I spoke to this on a previous podcast, was the experience to go and spend 6 weeks in Cabocho and work alongside Dr. Mangana and Dr. Marco at Cabocho emergency wards there. And just, oh, wow, what an out-of-the-world experience that was, to spend 6 weeks with my other colleague there, Cole Shaver. Really eye-opening, really put all of the learnings into a nice bundle and really put it in the context of remote and rural healthcare and some of the challenges that face some of those communities. The other highlight of the time was being able to go to do the in-person program in Malta for just over a week there and do the ultrasound program, the eye care program, and really get to share a lot of really just great tips, tricks, and learnings from students from all over the globe. You know, obviously there's some physicians in the program. There's some anesthesiologist residents from Poland in the program. There was a ton of and cruise ship nurses and a ton of just an incredibly diverse group of folks and individuals that come from various parts of the globe, that come from various facets of the healthcare community. And what was really interesting was no matter your professional credentialing, no matter your hierarchy within the healthcare system, it was a sharing of information. It was a sharing of knowledge that we have gathered through our practice that others may or may not have been exposed to. And just the opportunity to share and learn as peers within an education setting and have it facilitated by some of the incredible facilitators that Forum has to offer was just, it was an experience I'll never forget. And it really broadened my perspectives on global health. And we in North America are traditionally very siloed in how we do things and can seldomly look across the pond, as some would say, to some of the way things are being done elsewhere, but also how things are done outside of your contemporary healthcare system. Looking into more disaster medicine, looking into more remote and rural medicine, and looking at some of the challenges that go with, you know, as you continue to say, that prolonged field care aspect was just, again, what a great setting to learn and what a great amount of people to get to share that knowledge with, and what a bunch of great facilitators to learn along the way. So overall, the ACC program, I can't have enough good things to say about it. It was one for the books, and ultimately what motivated me to pursue the DHS program. And again, very, very similar experience thus far with a very diverse group and a very well-respected faculty facilitating that program.
So what was it that made you decide to do the Masters of Austere Critical Care? And there's tons of master's programs in Canada and US, in the UK and elsewhere. What was it that made you decide to do our program?
It's the big draw for me was the opportunity for a whole elective within doing in-person clinical work. What was really interesting is in vetting a lot of the programs internationally, there's been a large contingent of Canadians that have gone down and have participated in some of the programs in Australia. And what I really looked for was a program that reflected kind of how we do healthcare within our subsection or a subset of paramedicine. And the closest that I found to that was the austere critical care component, and the ability to have a facilitated learning both in Malta and both in Kilimanjaro in Tanzania was ultimately what drew me towards the program, as well as just overall the international attention that it has by bringing other people into the into the program. And it just lends itself to an incredibly diverse group of people and peers to learn from. The work that the college has done in Ukraine, the work that the college has done with Eric up in some of the Scandinavian countries, the work that you guys have done with John Clark in Africa, it all led me to kind of add a little bit more credibility and a little bit more desire to say, hey, like this is truly an international focus. And it looks at healthcare not only through the lens of your traditional static ICU critical care wards, but also takes that, adds another challenge to it and puts it in a resource limited environment, which I think where a lot of the learning comes from when it comes to having to think outside of the box, having to think about non-traditional methods and applications, and really making the best of what you have. It adds that additional challenge, both in academics and in medicine, that I don't think you get anywhere else.
I designed this program 7 years ago. I sat down with a few other knuckle draggers, and we're looking at people just like you. You are a critical care paramedic working in rural, remote, austere environments and wanting to upskill a bit on their knowledge and hopefully find ways to increase your practice. So obviously we included a ton of prolonged field care, and part of the austere critical care is the use of PFC and PFC concepts. But it's more than that, of building on to prolonged care for the level you are at the moment as a now master's level paramedic. Is there anything that we missed? I'm asking personally because at the moment we're revalidating the master's program and we're adding a ton of stuff. So what did you miss? What would you have liked to see?
That's super interesting, Aebhric. And a very loaded question. It's interesting. I kept a very open mind going into the program. I did my advanced care paramedic degree through a college in Northern Ontario, which had some similar remote and rural challenges. I had the opportunity to my CCP credentialing through University of Florida down in Gainesville. And again, both those settings were very focused on taking ICU learnings, taking critical care learnings, critical care unit learnings, and applying them in a interfacility application, moving from point A to point B. I think where your program really hits the mark is understanding and translating a lot of that information, a lot of that knowledge into you are now building the healthcare facility. You are now that static point where you're going to be bunking down and doing working on this patient for a matter of hours to days to potentially a week or so, depending on your extrication extraction plans. I think where I would love to see more is a lot more of that collaborative knowledge sharing across various members of the various master cohorts, and even looking at ways to have previous cohorts supporting current cohorts, because there's a ton of learnings and a ton of experience within all those individuals that really help support the international focus and the various amounts of challenges that come in working in various different environments that I think this program really tailors to. I think about my colleagues that work up in remote and rural, none of it, where they could be sitting on patients for a week. I think about my colleagues who are nurses on cruise ships who, your extraction plan may be the next port. And so managing that with the tools and kit that you have at the time can be quite challenging depending on the situation and the cases that present themselves. So looking for opportunities to really package in and bring the learnings and the lived experiences of the current students, the past students, can really be a good tool to look to layer in future learnings.
That's one reason I've started to find all of our graduates like yourself and have a podcast episode on you, on your passions and going through this program. And then, of course, we're going to focus on your thesis, your austere nerve block concept for your thesis. So we are trying to integrate the learning that people bring to the college as they go through our master's and doctoral programs. But is there anything else that you missed, or is there anything that we could be adding to this new master's in austere critical care? I
think the way that the current program has been packaged, Aebhric, is excellent. Like, one thing that I did miss that I know is an adjunct in some of the other programs in the college is mission planning. That was a big topic of conversation in the iCares program. And how do you go about planning a mission? How do you go about planning your deployments? How do you go about doing your environmental workups before? How do you set yourself up for success so that you may not need to be as challenged with some of the kit that you do bring? I think that that's something that was a topic of conversation that came up quite a bit in the iCares program, and really helps support some of the other learnings and modules within the ACC program, specifically surrounding remote and rural. There's a couple assignments that we wrote regarding how do you set up and manage patients in remote and rural sub-Saharan Africa. And I think part of that goes back to planning appropriately. So looking for opportunities to layer that and bring that learning in and support some of the other work that's going on with some of the other modules, I think is another excellent place to look to jump into and fold into.
One of the modules that I designed for this rewriting of our Masters of Austere Critical Care is the planning and skills and kit needed to create an austere ICU. So if you are in a very remote environment with just limited supplies, what do you need to plan for? How do you create an ICU, and maybe in a semi-permissive environment or in a guerrilla warfare environment or MSIW concepts? But how can you create an ICU that is evidence-based and cutting edge as best you can with nothing?
And I think that's an awesome spot to start to add that into. I mean, the other things that jump out to me when I think about that is, what's the environment that I'm working in? What is the inherent risk that the people that I'm going to be supporting? What's the population that I'm supporting? What's their risk profile look like? What are they more at risk for? What are they less at risk for? What are some of the surrounding capabilities of the local facilities? Is it a role 1, role 2, role 3? Is it a clinic? Is it a tertiary hospital that's got interventional radiology? How far away is it? What's my extrication plan looking like? Is it by rotary acid? Is it by fixed wing? Is it by dirt road down the side of Kilimanjaro? I think all those pieces really do go into forming an understanding that as you can prep as best you can to manage an acutely sick patient in the position that you are in, but also where's the definitive care located at? What is the challenge to get it from point A to point B? And that's where I think this program has a really cool blend of both traditional medicine concepts, but as well as interfacility and transport. And sticking that all in some of the most austere environments that this world has to offer, I think, and looking at those challenges individually, I think is areas that the program can start to look to layer in. And I think it would be fantastic to see that.
Yeah, we'll see what we can do. We're doubling the number of modules. So at the moment there's 10, and Dr. Chuba and I are putting together concepts for 20 modules that would allow each individual to pick and choose the topics that they want to focus on and design their own Masters of Austere Critical Care around the 18 electives that's going to be available.
That's fantastic. I know the electives were, at the time I went through the program, I want to say there's maybe 5 or 6 electives. And so inherently I opted for the clinical placement, which is one of the big draws of the program that I had, but as well as also the critical care transport module. And moving those patients was the two electives that really stood out to me as being valuable in my practice. And I think that's outstanding. We're looking at tailoring a little bit more of that, of the learnings to the operational environments or some of the challenges that future students are going to find themselves in.
Yeah, we looked at the student reviews, yours is included, as they go through. We see the feedbacks in each module on what they liked, what didn't like, and what they needed, and we're creating this new rewrite using your reviews as students.
And that's that plan, do, review cycle, I think, in its finest form there. And I'm so excited to see that this program is continually being improved from an already amazing standard to something that's going to be even more impactful in the future.
So, Greydon, I've invited you because you have completed the master's program and you have a master's thesis on nerve blocks. So tell the listener, give us an elevator pitch on your concepts for your master's thesis.
So my brief elevator pitch here, Aebhric, currently within our healthcare system and currently within the operational environment that I'm in, we've got a very big challenge when it comes to delivering quality healthcare of any level in remote and rural Canada, specifically remote and rural BC, where you have small communities that are scattered amongst the just under a million square kilometers that we cover, and looking at ways to improve outcomes, improve experiences, aligning with that quintuple aim concept. One of the things we identified was pain management. Pain management is, I think, as any paramedic will tell you, is probably one of the most satisfying things to manage and to work on, because it's one of those things that you can make an immediate difference to someone else's experience, regardless of what the nature of the traumatic injury is. It's something you can make an immediate impact, and something that downstream will have even bigger impacts as to how they recall and how they remember the experience through that journey. And so looking at ways that we can better manage pain in some of these remote rural centers was something that really drew me in, and was something that I ultimately wound up writing my thesis on. And funny enough, I wound up writing the bulk of my thesis while I was in Tanzania at Kilimanjaro, where we were actively practicing some of the nerve blocks and some of the local anesthetics that we were doing at the time. And so it was great to see that in a remote rural context in live time while I was writing my thesis. And there's many late nights in the blockhouse up the hill from Kobosho. But overall, I'm happy with I'm happy with the studying that was done. I'm happy with the literature review that we did. And overall, it's something that I'm definitely looking at leveraging into my future academic studies, and seeing how we can look to use some of the learnings that we've seen abroad, and seeing how we can really create some policy reform here in Canada and support evidence-based practice when it comes to progressing how we manage pain in the remote rural setting.
Nice. So what nerve blocks did you do in Kobosho?
So we did a number of nerve blocks. We did supraclavicular nerve blocks, and we did femoral nerve blocks by the practitioners there. And it was very much without the limited advent of ultrasound. As we now learn, ultrasound is probably one of the gold standards when it comes to point of care imaging and when it comes to managing and implementing nerve blocks. And we did a number of local blocks as well, whether it's ring blocks or things of those nature to manage more invasive wounds, or to manage small amputations and things of those nature.
Did you do any of the posterior tibial blocks?
That one I did not have an opportunity to see or work on when I was in Kobosho.
That's something we use a lot in the Army, because it just blocks the bottom of the foot. So any blisters or any injuries like that will immediately cut the pain to the injury.
It's interestingly enough, that is it's one of the things that's got a very specific use. The nerve blocks we went after as part of this literature review mainly focused on the stuff that we have for the high ticket major trauma items. So such as humeral fractures, tibial fractures, femoral fractures, hand and wrist fractures, stuff of that, aligning with that nature. And really looking at what other agencies are doing, what other organizations are doing, how effective they are from the studies that have been done, and how we can fold those into practice here in Canada was really kind of stuff that underpinned parts and sections of the thesis study.
And in your current practice, what would you be allowed to do? Which blocks are you doing in Canada?
So right now, as it stands, we don't actually have language within any of our policy that allows for specific blocks. We have just started over the last 2 years to be endorsed for local anesthetic for invasive wound management. Traditionally, we've been giving sodium channel blockers, specifically lidocaine, for many, many years here for dysrhythmia management in Canada. And then we've just started to really start to jump on the POCUS train and get into point of care ultrasound. It's been something that's practiced at the critical care paramedic level in BC for a number of years now. And it's now just starting to kind of work its way down to the advanced care paramedic level. And so when we look at all these components, we really see an opportunity to change some of the language in some of the policies that we have governing our practice. And really there's an opportunity to lay the groundwork to allowing for more invasive nerve blockades further down the line as we look to really improve patients' experiences and the overall impact of healthcare, especially when you look at targeting some of these remote and rural communities that have transport times in excess of 4, 5, 6 hours. And some of them come from remote areas that you're coming down a dirt track road, where traditional use of morphine, fentanyl, hydromorphone, all your opioid-based analgesias really get eaten up either because of the long transport time or because of the nature of the transport. You have a metabolically driven patient that's going to consume that medication faster. And overall, you do have a higher risk and exposure to hemodynamic compromise when you start looking at opioid-based analgesia plans. And so looking at something that's more evidence-based, looking at something that's more feasible and practical from a long-term sense to move these patients was something that I really saw an opportunity in. And I think that there's the language in our policies that allow for the bulk of the work for the more invasive nerve blocks. We just need to change or allow me to change some of the language to support the actual conduct of those procedures.
Do you think that there'll be options in British Columbia for you to do that? And will this research that you've been doing help move that forward?
I think that a single point of research won't necessarily move it forward. To really see some feasible change here, there's got to be a lot of different people that come to that table. And you got to have various areas of your policymakers. So you got to have the Ministry of Health involved. You have to have the big drivers of healthcare in the province involved. So the predominant and the sole pre-hospital care provider, the ambulance service here. You got to have probably some other facets of healthcare involved, as well as union representation and lobbying. You should, as well as looking at support from some of the physician groups or some of the rural care providers to really say, hey, this is an opportunity that we can capitalize on. And so collectively, we can bring not only this information to the table, but also practices that have been mainstays in other areas of the world together. Possibly look for the opportunity to drive a study home, to drive a small cohort to execute on a trial basis for those skills, and then look at what the impacts are, look at what the outcomes are, and drive it in a evidence-based, data-driven manner. And so I think if you get the right people to the table, I genuinely think that we can start to advocate and start to push forward some of these improvements in patients' experiences and how they go through their journey through the healthcare system, especially in rural and remote areas.
You mentioned POCUS as well. I'm happy to hear that your organization is pushing forward with point-of-care ultrasound along with nerve blocks. They kind of go hand in hand, don't they? So if you have the acuity, the ability within POCUS, having a handheld ultrasound, you can be better at nerve blocks and be better than we were starting out. And years ago, we just felt where the femoral was and kind of put our hand down, felt where the femoral artery was pounding and kind of go lateral, hoping that you didn't hit the artery. Now you have science. Now you have ultrasound. It's going to help you. And you're doing both at once.
Yeah. And just to add some clarification there, we're currently not using the POCUS or the point of care ultrasound for nerve blockades. They're prominently used for in-field point of care imaging, for fast examinations, for rest examinations, to help support pre-hospital blood administration. And we're starting to see some of these, because in Canada, we've got a couple different layers of healthcare governance. And what we're seeing right now is we're seeing reform made within the licensing level. So what us as individual practitioners are able to do. And then we're looking at some of the care providers here in Canada, whether it's the provincial ambulance service, whether it's smaller private entities that are contracted for industry purposes. We're starting to see them take some of the new language that we've seen in the licensing areas and start to find ways to make impacts for patient care in their own practices. And so I think we're still a ways out from seeing a point of care ultrasound utilized for nerve blocks. I think we need to create at least a local case use for it here in Western Canada and really hammer home and lean on the fact that we can make a big difference to some of our patients moving between facilities that's in excess of 3, 4, 5 hours. And that's where I think the big difference can be made in these situations. Not necessarily supporting the point of entry, but supporting initial point of transport with some of these rural health clinics that we support.
So you mentioned transport times of 4, 5, 6 hours. That's prolonged care. That's dealing with a casualty for extended periods of time, and you have all your Hitman sheep vomit problems with your casualty. On top of that, if you're not doing a nerve block, what do you do? You're snowing them under with ketamine or Midaz, or how would you treat this casualty?
So typically right now in the framework, in the system that we work in, you may get a loading dose of long-acting opioids from the facility, whether that's hydromorphone, whether that's morphine. A lot of the communities' access to advanced practice may not be there. And it really boils down to the comfort level of the individual practitioner and physician. Worked in communities before where we've had the opportunity to watch it was a doc from South Africa that was working in remote northwestern BC that had moved, and he was very, very comfortable with femoral nerve blocks for lower extremity injuries. And so he performed the nerve block right then and there. And this was early on in my career. And the more I got to understand the system, the more I understood that that was an anomaly. So looking for opportunities to manage that type of pain more effectively, I think outside of what we normally have right now, which is inhaled analgesia, so Entonox or nitrous oxide, as well as oral analgesia, so your Tylenol, your ibuprofen, or your paracetamol for your listeners from across the pond. We've just moved to the use of IV paracetamol, IV Tylenol within our organization. That's had a lot of really good effects. And while those are great adjuncts to pain management, I think I reflect back on my time that I saw the nerve block done by the South African physician, and the instant relief that was then able to move this patient 3.5 hours by ground, because specifically up in northwestern BC, we kind of get the weather can be fairly challenging at times, and the availability of air-based resources is really triaged on the needs of the province and the needs of the patients within that 100 square kilometer or 1 million square kilometers. So that patient had to go by ground. And so going on a moderately managed asphalt road that's got bumps, all sorts of stuff in it, overall, I think nerve blockades was just a much more effective way of managing that patient's pain rather than looking to utilize IV analgesia, whether it's opioids or NSAIDs.
You mentioned Entonox. How many bottles of Entonox are you going to take on a 6-hour commute?
That also begs the question of how much of that Entonox is being exhaled into the space that you're sharing with the patient in that back of that patient care compartment.
Indeed.
Obviously, we've had a lot of success across the globe with Penthrox as being another great inhaled analgesia, which is another option that we can consider here, depending on which organization you're based with. So there's options out there. But as far as reaching for best practice, I think that we need to start looking outside of the conventional box, looking at some of the procedures that are being done in hospital by anesthetists or by physicians that respond out of hospital, pre-hospital, like they do in the UK, in aspects of the UK and some of the other Commonwealth countries, and looking to see how we can make some big strides in changing patients' experiences moving between facilities.
So at the moment, before you commute for 6 hours with this guy, are you stabilizing him at a local clinic? And is there a doc there that could do the nerve block before you commute, before you take the person?
It depends. It depends on where you are. It depends that physician's comfort level. It depends on a whole variety of factors. We're starting to see more and more use and application of nurse practitioners to help manage a lot of primary care needs within more rural areas of British Columbia. We're starting to see nursing stations be a little bit more prevalent. Sometimes physician availability is challenged because they're out of community, because there's only one physician for the community. So it is really hit or miss depending on where you are, depending on the capabilities of the facility, depending on a variety of lived experiences and qualifications as to what you're getting pain-wise. And, depending on how long that people have practiced in the system, a lot of people become comfortable managing pain via the use of opioid-based analgesia and more recently NSAIDs. And so looking at, like I said, really looking at areas that we can improve in that, because at the end of the day, like we've talked about, and what's well documented in the quintuple aim is how do we change patients' experiences as they go through the healthcare system, as well as just how do we bring healthcare equity in general from large urban centers and have that in a more accessible, have some of these things more accessible in remote and rural areas that people lived in for decades and just have no desire to move to larger communities where these services are more prevalent. So really looking at it from an equity standpoint as well, I think can also form the foundation of looking to improving how people experience their healthcare, especially specifically when it comes to pain management.
So Greydon, you've pushed evidence forward a bit with your thesis. So now you're enrolled in our doctoral program. What do you plan to do? Are you building on your concepts of austere nerve blocks, or are you tackling a new niche of the pie?
It's a very loaded question. I want to say I'm going to leave it open for now, but I do want to do some work in and around remote and rural healthcare equity, whether that's building on pain management, whether that's building on access to advanced care in some of these communities or critical care in that regard. Really looking at areas and opportunities within our remote and rural populations to make a profound difference as they move through As they age, as they have more chronic health problems, as they have acute healthcare problems, whether it's in the form of traumas or anything of that nature, really looking at how we can better healthcare equity in some of these areas that are 2, 3, 4, 5, 6 hours even from definitive care from large tertiary hospitals in the absence of quick and effective transport, either by fixed wing, rotary wing, or by ground transportation in that regard. So looking at some work in and around there, I think, is going to be the focus moving forward. But I'm keeping it open for now. It's the early stages of the DHS program, so I'm open to having my mind change as I converse more with the cohort and some of the facilitators and the faculty, and just, again, learning on some of the experiences that they've had internationally and how we can look at adding those things here in BC.
I'm looking forward to seeing what you can do there. So, Greydon, my final question for you is this. What advice do you have for the medic, the nurse, the doc who is thinking about enrolling into our Austere Critical Care program?
I want to say my advice is going to be, you won't regret it. One of the big things you'll take away is you're learning amongst a group of equally of peers that are equally driven by a hunger for knowledge, a hunger for improving their own practice, and a hunger for being the best clinician that they can possibly be. And by undertaking a graduate degree, I think is a strong sign of their willingness to step out of their comfort zone and a strong willingness to learn from others. So take the opportunity that's been gifted in the program, in the cohorts that you do work alongside, and look for the opportunities to absorb as much knowledge as you can from those around you, from facilitators, from the faculty, who all have equally diverse and incredible experiences of their own rights. And it will not be, you won't regret it. I can say it's probably one of the best decisions I made, and it's one of the things that I definitely am going to push forward to everyone I know that's looking for some postgraduate credentialing in these fields.
Well, Greydon, it's been fantastic to see you go through the program. I'm delighted that you're going to continue with your studies with us, with your doctoral, and I look forward to chatting with you again.
Likewise, Aebhric, I always enjoy the opportunity to jump into these conversations with you and enjoy some of the banter that we get to have back and forth. And I love listening to a lot of the other guests that you have on the podcast, and am a weekly listener.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.